There's a number of high met needs. First, we're still improving. We made a vast improvement in terms of how we stage the tumors, but there still is a long way to go in terms of really identifying those tumors that are high risk for poor outcomes. We've certainly improved that staging system with either the alternate Brigham and Women's staging system or just the improvement in the American Joint Commission on Cancer, the AJCC system. But there's still a number of patients who are staged in high-risk groups who don't have poor outcomes, and we don't want to inappropriately treat them aggressively. So we need to still do some work in better stratifying and identifying those patients that truly are at risk for poor outcomes. And then we need to identify what is the appropriate best treatment for those. Should we be, in addition to surgery? And surgery is the gold standard. There's consensus that when possible to resect these tumors, but should these patients get radiation? In which cases should they get radiation afterwards? Or now with the advent of immunotherapy and some recent really exciting data around neoadjuvant utilizing immunotherapy before surgery and potentially having a benefit for using it afterwards, would this be replacing radiation? Is it used in conjunction to radiation? Or there's some other recipe, and how do we really think about that for these really high-risk patients? That's really, I think, what's exciting for many of us who work on that spectrum of the disease, the advanced disease, figuring out which of these patients should we be really aggressive with and what does aggressive really look like.